All right, thank you again and welcome back. This is part 5 in our revenue cycle series. Today we're discussing challenges with charge capture 201. So we're going to get a little bit more in depth today about those challenges. And let's start again at the top with the maintenance and accuracy and completeness of our charges. Have you spent the time, as I discussed in the previous presentations, to get those charge descriptions up to date, accurate, and synchronized throughout your organization's data master files, your item master, your charge master, and your PDM? Have you put the adherence in place to your policies and procedures? Have you even documented the policies and procedures like we discussed? If not, you need to get those in place so that we can start the process of adhering to them. And have you discussed any concerns as far as resources? I know we talked a little bit about this in our previous presentation. Everyone has some resource constraints from an organizational perspective. So have you discussed who's going to handle what aspects of the charge capture process? And what do you do when a challenge is presented? Who do they go to? We didn't talk about that as much in previous presentations, but you need to have that accountability stream, if you will, or process flow in place so that they know who's the next level of communication necessary. And now let's talk a little bit about some of the other challenges from technology. I talked about how you can optimize your technology and what types of efficiencies technologies can support. Well, what happens when you have limitations with your technology? I know this won't be foreign to our supply chain folks or even some of our charge master folks who are listening today. What happens when you don't have enough characters within your system to define the actual product or service that you're offering today? Or what if you only get to have one primary NDC number in your pharmacy data manager? How do you go forward with that? What processes do you have to put in place when your technology is limiting, your effectiveness or your accuracy in your charge master? Well, these are some of the situations that we're going to discuss in a little bit more detail, and we're going to give you some of the solutions involved in that. And the regulatory compliance perspective, the updates are always a challenge. We're still talking about those as we have in our previous presentations. And we need to start with our interdepartmental communication to support those updates. So have you put that process in place that I discussed? If you have, then you should be good to go. Your folks will know what the changes are, what the updates are, when they become effective, and what they need to do individually to help support your compliance program. And the standardization, again, are you at a corporate level or are you at a facility level? If you're at a corporate level, are the people in the corporate level communicating down to the hospitals what the process is for charge capture? Or have they even considered the nuances that you may have, say you're a psychiatric hospital in relationship to maybe their orthopedic hospital within the network? These are concerns that you have to discuss when you're looking at something globally, but you're trying to charge for it independently. So you want to take that into effect when we start discussing some of these challenges. So again, how do we do the maintaining accuracy and completeness aspect of charge capture? Well, you want to have a live, fluid, ever-changing process, but you want to make sure that even as it's changing, it's being documented and adhered to and communicated. Like services are sometimes a challenge in the charge capture process. So if you're doing the same service and you're doing it in different departments, have you put the process in place that it's synchronized, that it's like, so that someone who's working in your orthopedic department and someone who's working, in your surgery department are really working with this, the same information, with the same pricing, with the same charge description, master description. Any little nuances can cause some confusion and can promote some charge capture errors. So you want to make sure that you have those processes again in place. We talked again about our standardization for our physician preference items. How's that being addressed? Do you have your value analysis process up to date? If you do, if your teams are communicating, then you should be good to go with that, and that should maintain your accuracy and your completeness. Do you have your administrative support in line? I know a lot of folks think that the administrative staff is handling all aspects of charge capture, but as we discussed in our previous presentations, they're not. The clinicians are the front line here. They're doing the services, they're choosing the charges in a lot of aspects, but they have to be communicating to the administrative staff, and in turn, the administrative staff has to be there to support them when they tell them that that screw was not easy to find and that screw was $1,000, not the 15-cent screw that was in the charge master today. So you want to make sure that you've communicated that well and that you're working in tandem to get the most out of your CDM, your charge capture process. I talked a little bit about the charge descriptions earlier, whether or not if you've created them, whether you have system limitations around them, whether they make sense. So what do we do if the hospital has decided to create their own? Has that been communicated at a entity level, or has that been communicated at a global level if you're, as I said, a multi-hospital network? Or have you decided to go with a standard set of hospital descriptions? You know, have you decided to go with CMS short descriptions or long descriptions? If you put a process in place, that's fine, but you need to adhere to it and you need to communicate it, because your folks won't know what it is unless you tell them. There's nothing worse than having one description in the charge master and another description in the item master, and those not meshing and not making sense, and then you have billing concerns, or you delay getting your claim out the door. Do you have one resource to handle this from a description level, or do you have multi-resources? Who's entering the charges? You know, again, that's another challenge you have. If your resources are scarce, then you need to make the most of the resource that you have. Make sure they have the correct information, they're armed with the methodologies we discussed in our previous presentations, and they're ready to address these challenges and concerns. So we're back to our adherence. We've talked about our policies and procedures throughout our other presentations. Let's talk about what happens when we put some of these policies and procedures into effect. Have we scrubbed our CDM for code changes? You know, that is a policy and procedure that most hospitals have in effect, but is it really happening? Are your additions and deletions being handled as they arise, not 6 months later when someone realizes that 5,000 bills have gone out the door without the correct information or with an old charge code on them? Have you reviewed your compliance issues? Have you really addressed at the root cause, as we discussed in our previous presentation, how to make that change and what steps you should put in place to make that change? This all has to happen at the charge capture and revenue integrity level, and again, that communication factor back down to the folks on the front line making these decisions for your patients and for your charging. Have you set up new departments with like line items? I know that may seem a little bit foreign to folks, but you know, I talked from the very beginning of the presentations that if you don't have a charge in your charge master, you cannot bill for it. So have you specifically addressed where these charges need to go when you set them up? It's not good enough to just say, oh, we have a new hip, we're going to put it in this department. You have to make sure that every department who's going to handle a hip, probably not the best example, but you know, maybe a chuck or a cup or some other type of service that is, you know, throughout your organization needs to be dressed in that manner. Make sure every area where you're going to be charging has that capability to charge so you don't miss an opportunity for revenue. Now let's talk about pricing. We talked earlier about having like pricing. That's great. You're doing the right thing for an organizational perspective and best practice, but have you put a defensive pricing policy into effect? What do I mean by that? I mean, can you sit up and defend what you're putting into effect? Are you unanimously charging the same thing throughout the organization for that same screw? Or when you set it up in 3 departments, the different departments charge differently for it because one department is still working on an old charge entry form or an old, patient care form, whatever the case may be. And have you addressed increases as they come throughout the year, or have you made a determination you're only going to address any of these changes annually? Whatever the case may be, as long as you've documented it, put the policy in effect, and monitored it, then you should be able to address the challenge appropriately. And we talked about our facility CDM maintenance. Who's doing it? And who's working with each other to make sure that it's compliant and accurate. If you're doing it at a global level, at the corporate level, then make sure that those folks, again, are communicating to the department heads. Are the department heads reaching out to someone in corporate when they get notification of a change or when they get a new product? Or is it going to be a situation where a new product's been sitting on the shelf for 6 months, no one knows how it got in the door, but we inserted about 15 of them and no one's charged for them? They're the situations, the challenges that we've tried to avoid throughout these processes. So if you're adhering to your policies and procedures and you've done all the work up front, you should be good. So we talked lastly about our technology limitations in our previous presentation. Now we're going to get a little bit involved about what those limitations are and how we can afford some opportunity to correct those. So again, what's your setup? Make the determination on how you're going to set it up. Corporate versus facility. Make sure it's like. Are you dealing with a one-to-one ratio or a one-to-many ratio when it comes to your item master and charge master mapping? That's a decision that needs to be made at each hospital's level. They need to determine whether or not they want to do a one-to-one mapping, whether they want to do a one-to-many mapping, whatever the case may be. You just have to be able to support it and maintain it. It's your decision to make. Just put the policy into effect. We discussed who's managing the process. Well, that could be different from one hospital to the next. Do you have a revenue integrity department who's managing charge capture, or is it your CDM supervisor? Is it your IT department? We've now seen some IT resources popping up throughout the industry where the IT folks are getting more involved in charge capture. Or is it finance? Ultimately, I think you're going to see that it rests at the financial level, because at the end of the day, the finance department is responsible for making sure the hospital keeps its doors open. So you want to make sure that you're communicating any of these process changes back to them. Okay, we discussed earlier some limitations with the software. Are the characters limited in this particular software program, or does your CDM have limitations where you need to start it in a particular way? Whatever the case may be, you just need to decide how you're going to manage it. So if you put a policy into effect that you're going to call chucks, then let's be consistent throughout the board. If they're going to be under pads, they're going to be under pads. If you're going to turn around and say that we're going to use this CMS short version of the descriptions in our charge master, and you're coordinating that with your item master, then you should be good. You should handle that challenge well. If you haven't, and you haven't monitored the process and someone else is responsible for making updates, you may run into it again and again. So again, getting back to that root cause when you're dealing with some of these limitations. Again, we talked about resource concerns as well in our previous presentation. So let's talk about a little bit more today and what are the solutions to these challenges. Maintaining systems from a charge capture perspective accurately and efficiently is not the easiest process. You have a lot of interoperability going on with charge capture. You have to make sure if you have medication management systems that they're coming in. You have to make sure from a pharmacy perspective and item master perspective that all of those are being synchronized and maintained at the time that they need to be maintained in order to support your revenue integrity. So you want to make sure that you're doing what you need to do at administrative level, at a revenue integrity or charge capture level to support these resources. If they're wearing many hats, as we discussed before, you want to make sure they have documented policies to refer to. You want to make sure that the policies are being implemented appropriately. When there's confusion or concern or questions, that you're addressing them in a timely factor. And you want to make sure that all the folks know what their place is. They know what their job is. They'll be able to perform appropriately. So do you have full-time resources or do you not, as we're discussing these concerns? Maybe you just have a CDM manager who handles all of charge capture, revenue integrity. That's fine, but you have to be aware of the limitations of someone, wearing many hats in your organization, and you want to make sure that you're communicating as effectively as you can to make their job easier and to make sure your charge master and item master are being maintained appropriately. Are you having some data mapping challenges? Most hospitals do. If that's the case, from a resource perspective or from a technology perspective, you want to make sure that you're addressing those, that you have a plan, again, in place that will help and assist the people who are doing this from the ground level up. If that means communicating to your administrative staff that you're going to, work in this methodology going forward rather than the one that was in place, then just make sure you've communicated that. And again, going back lastly to our synchronization of these processes, who owns the process? We discussed how to put the process in place, how to document it, who should be following it, who's responsible for monitoring it, whether it's the charge description master team, revenue integrity, the supply chain, materials management, or finance. You just want to make sure that you have that down so that people know what they need to do and who they can go to if they have issues. All right, let's talk a little bit about our interdepartmental communication, since we're talking about who owns the process. So who are the players? Who are the people who are in charge of developing your charge capture processes? Have you invested time to get everyone on the same page, as I discussed? Do your clinicians and your administrative staff buy into what you're selling? If they're not really invested in your process, going back to what we discussed in our earlier presentations, then your chances of success are a little bit limited. So you want to make sure that you have the support of all involved. And you want to listen to the people who are actually tasked with doing this work, so that if you need to make changes and adjustments based on what their workflow is, that you've done it and you've done it appropriately. Valuable insight will be returned if you do. I assure you that when you go to the people who are doing the work day in and day out, when you listen to what their concerns about your policy, your procedure, your methodology are, that chances are you're going to come out better when you put some of their advice into effect. That doesn't mean you have to listen to everything, but you want to listen. You want to have an open mind when you're addressing it. Standardization, we discussed this throughout our other presentations, facility, corporate level. What's your approach? Again, you define what your approach is, but then you want to put into place how you're going to address it. If your physician preference items are being addressed at a corporate level, then that's fine. But make sure your corporate level is communicating down to your physicians at a facility level that is not their decision to make. You don't want things coming through the back door through the OR, or things coming out of a vendor suitcase that someone in charge capture has never even put into the charge master. You want to support your CDM build, whether it be a one-to-one or a one-to-many relationship. You want to make sure everyone's aware of it. You want to make sure that it was communicated and accurate. All right. Lastly, let's talk about our regulatory and compliance updates. Your staff is challenged with daily activities. Their time's limited. Their resources are strained. Regulatory updates, they occur. They maybe send out a little bit of notification through an email or something of that nature. They come across at the departmental level, or a nurse gets a message in her inbox. That can be very taxing for people who are actually doing the work and responsible for carrying it out. So again, you want to make good use of your professional organizations, your vendor webinars, your webcasts, your white papers, all of those resources that are out there to support you and support your organization. As I said, podcasts and webinars, as we're offering today, are very informative, can be done sometimes in the clinical environment. They can be done, at an at-home environment. Whatever the case may be, you want to make sure that you're filtering that information down in the most effective way possible for the people who need to get it. Misinformation or incorrectly interpreted rules are going to be a problem. So you want to, again, make sure that you've checked your facts before you've disseminated the information. So you don't want to just pass on a rule that you think you heard from someone else in the department. You want to make sure that you've checked it, make sure you've gotten the regulatory adherence policy down, and then you send it out to your staff. We don't want anyone implementing the wrong rule or the wrong edit or anything of that nature. All right, so that's all for today's session. We're going to go forward with our next session in our revenue cycle webinar, the complexities of revenue cycle charge capture processes. So please stay tuned.